Thank you very much, Miranda. Welcome to this one-day course in the dietary management of irritable bowel syndrome. It's a pleasure to be speaking about something that I think is absolutely fascinating and I know is becoming a really, really enormous area, not just for dietitians, but for all health professionals, and that's the interaction between the microbiome and probiotics and prebiotics in irritable bowel syndrome. I'd love about an hour to speak about this. Unfortunately, I don't. I have 20 minutes, so this is going to be a really, really whistle-stop tour. But hopefully at the end I'll give you some really good tools that you can take away and use in your own clinical practice and to form the basis of your future reading. So we've seen this diagram already, and really it's here to identify that although I think the microbiome are important in IBS, let's not throw the baby out with the bathwater. There are a variety of other different mechanisms that drive the pathogenesis, the pathophysiology of irritable bowel syndrome. So stress, anxiety and depression are really, really important. So if we spend all of our consultation just focusing on the microbiome or on probiotics, we're missing out the patient, the rest of the patients sitting in front of us. So there are a variety of cognitive, behavioural and physiological mechanisms that are likely contributing to the symptoms that people experience in IBS, and clearly the ones that we're really interested in are the ones down here, the food hypersensitivity and the interaction with the microbiome, and that's all I'm going to be talking about. But this is a warning to say, don't forget that the person is complex sitting in front of you, and probiotics are not going to cure all of those other things. So think holistically about the patient, and if they're presenting with lots of stress, it's your responsibility to at least in some way discuss that with them. Okay, but I'm talking about the microbiome. This is the gut here, and I'm going to talk to you about the range of different bacteria residing in the gut. First of all, we used to think that the stomach was sterile because its pH is anywhere between 1.5 and 4, and therefore we thought that bacteria wouldn't be able to live in there. But actually that's not true at all. With the discovery of Helicobacter pylori, we know that there are many bacteria living in the stomach. But not too many, not compared to when you get to the small intestine, when you get much larger numbers, and they go up to about 1 million bacteria per mil. And they start to diversify a little bit by the time you get to the small intestine. You start to get lactobacilli and gram-positive cocci. But it gets really, really interesting once you get to the colon, because that's where the enormous biomass of the bacteria live in the gut. So, and we have about 10 to the power of 12 bacteria per gram of stool, and I really want you to think about that number. So you all know that 10 to the power of 12 is 10 times 10 times 10 times 10 times 10 times 10 times 10, 12 times. And that is the number. And that is the number of bacteria in a gram. So that is the number of bacteria in 1/5 of a teaspoon. So when you go to the toilet next time, in 1/5 of a teaspoon of your stool, don't get a teaspoon out in the toilet, you will find that there are that many bacteria. We used to think they sat there and they were fairly benign and didn't really do anything, but now we realise they have an enormous impact on our health and on disease, and we're only just starting to begin to understand what some of those mechanisms are. So it's a really exciting area, and it's one that I think will cause great discovery in the next 10 to 20 years. And here's what they do. They don't just sit there and be benign. Here's what they do. I'll try and talk you through this slide now. Here is a review paper we published many years ago, but fundamentally some of those mechanisms still apply. So you can see, I'll orientate you, the luminal microbiome going down here. So this is the hollow tube. The microbiome also live on the mucosa though as well, so they sit there as well. And then these are the enterocytes, the colonic epithelium that lines the gut. And you can see a key role is that the luminal microbiome ferment non-digested carbohydrates. We've just heard that from Dr. Rossi, to produce gas and short-chain fatty acids. It's the gas I will speak about later when I'm talking about FODMAPs, but also they're producing short-chain fatty acids. The underlying mucosal immune system here, and particularly this important cell here called the dendritic cell, you'll remember that from your immunology, is responsible for sampling, constantly sampling what's in the mucosal microbiome and what's in the luminal microbiome to detect what's going on there and to signal whether it's going to say, right, this is a harmful bacteria, I'm going to start inflammation, I'm going to start producing lots of inflammatory cytokines, or it's a benign, harmless bacteria, in which case I'm going to be tolerant to that bacteria, in which case it doesn't. And in fact, if you have things like probiotics in your gut, it will detect those and it will say, perhaps this is not, it's immunoregulatory, this bacteria. I will dampen down inflammation here. So the key to how our body responds to the bacteria in our gut is the dendritic cell, because it is the key messenger which tells our immune system whether this is something that we should be causing inflammation about, or we should be doing nothing about, or we should be having an immunoregulator response. So the dendritic cell is actually really, really important to us. I would love to spend about half an hour talking about how we know that the microbiome you have in your gut is related to IBS, but I don't. So what I've done is I've summarized it in those 4 points there. But I've preceded it by saying that there are a variety of cognitive, emotional, physiological causes of irritable bowel syndrome. But we know, for example, that the microbiome are important because we know there is an increased risk of IBS following gastroenteritis. Here's a really, really interesting study done in Canada where there's a big outbreak of gastroenteritis in a really, really isolated town. And so a big public health disaster happens when loads and loads of people in the town get gastroenteritis. Because it's an isolated town, it makes a really, really good model for doing research. And so what they showed is 2 years later, people who got gastroenteritis were 4.8 times more likely, so nearly 5 times more likely to have IBS 2 years later, compared to people who at the time didn't get gastroenteritis. And so we know that an episode of gastroenteritis can often be the thing that precedes the onset of irritable bowel syndrome. So, I mean, it would be interesting to start asking your patients when their onset of IBS was, whether they associated that with, did they have gastroenteritis before that, or any other factors preceding that. We know that the luminal and mucosal microbiota are different in people with IBS. I could cite hundreds of papers here, some of them we've done ourselves, but there's a really, really great one published in January's issue of Gastroenterology, which shows that the luminal microbiome are different in people with IBS compared to people without IBS. So these are case control studies. And we've also done studies to show that the mucosal microbiota is different. So we've taken biopsies from people with IBS and shown that their bacteria on the mucosa is different to the mucosa of people without IBS as well. So we know there's a difference. We don't know whether that's a cause or a consequence. So do those differences cause them to get IBS, or does the IBS cause them to get different microbiome? We don't know that, and it's very difficult to determine that in human studies. We know that there are alterations in the pattern of fermentation in some people. So because you've got different microbiome, it's hardly surprising that you might have a different pattern of fermentation. I'm going to talk a little bit more about that when I talk about FODMAPs a little bit later. And fourthly, we know that there is an increased stimulation of the gut immune system in IBS. If I'd have said this 5 years ago, people would have laughed at me. But over the last 5 years, a series of studies have been published to show that people with IBS, actually some of them do have a mildly elevated immune stimulation. People always think if it's inflamed in the gut, then it's inflammatory bowel disease, but actually these studies imply there may be a low-grade inflammation in some people with IBS. So what I've done is I've also cited a really, really nice review paper. If you don't have time to read all of those original papers that I've cited there, what I'd recommend you do is read that Barbara paper, which published in Gastroenterology. Giovanni Barbara was on the Rome committee that looked at the mechanisms of the microbiome in IBS. Published last year in Gastroenterology. I would recommend as a really nice review paper. That's where you start. Okay, what we're interested in though is not the presence of those alterations, but actually of course what we can do with them. And so I'm going to mostly talk about probiotics in this lecture. Probiotics are live microorganisms that when ingested in adequate amounts exert a health benefit to the host. You all know the sorts of things I'm talking about. And there is an extensive body of research on probiotics in irritable bowel syndrome. So there are at least 35 different randomized controlled trials of probiotics in irritable bowel syndrome. And here's a meta-analysis published back in 2014 now, one of a number of meta-analyses, and I will come on to that in a moment, that have been published. So have a look at this meta-analysis. And what it tells us is that if you look at all of the different randomized controlled trials, the relative risk of having symptoms after taking a probiotic is 0.79. So i.e. you have a 21% reduction in your risk of having symptoms after taking a probiotic. So that's the statistic you can use with patients in your clinical practice. We know that got a 21% better chance of not having symptoms after taking a probiotic. But what this meta-analysis did is it also did sub-meta-analyses on the different types of probiotics. So it did one on bifidobacteria, E. coli, streptococcus, lactobacilli, and combination ones. There is, however, a big problem with doing meta-analyses. We've spent all of our lives teaching people and being taught that meta-analysis is the gold standard, and I hold my hand up and say that is absolutely true. But a meta-analysis of probiotics is slightly troublesome in some ways. There are good things about meta-analyses. So I wrote the editorial based upon this particular meta-analysis, and there are real advantages of meta-analysing probiotic data. First of all, you can synthesize lots of poor quality trials together so that you can look at individual, just maybe the high quality ones together. Loads of the probiotic trials are really, really small. So of those 35 trials, 9 of them included less than 50 people. So when you have loads of small studies that might not show you anything, if you meta-analyse them, you add them together, you've got a lot better power. And so you can better detect the direction and the strength and the size and consistency of any effect. So really good to do meta-analysis. But there are also some real limitations of meta-analysing data on probiotics. Firstly, each probiotic is very, very different, and there's some significant heterogeneity. So for example, if I were a patient, I'd want to take that probiotic there because that was significantly better than that probiotic there. So it's all very well saying to a patient, yes, go and take a probiotic, there's a 21% reduced chance, but there isn't a 21% reduced risk because that has a much lower risk and that doesn't lower the risk at all. So unfortunately, we can't just say, yes, probiotics work, because the question we should be asking is which probiotics work, and that's what I will discuss now. Unfortunately, to help us, we have the BDA guidelines on probiotics in IBS. This is an absolute must-read paper. What I will do is, for those of you who are on Twitter, I will tweet a link to this paper in a moment so that you can quickly go to it. But even if you don't, please go and look at this paper, read this paper. It's in JHND. As a BDA member, you will have free access to it, so please do go ahead and read that. What they did is the gastroenterology specialist group, led by Miranda Loma, published this review. And what they did is they systematically reviewed all of the systematic reviews. They found 9 different systematic reviews of probiotic trials in IBS, covering 35 different randomized controlled trials. And that's what I'm going to talk about now. And what they've done is they've produced a grid. Now, you should all have this grid in your pack, in your course pack. What we've done is, I'm really hoping you all do. Can I see some coloured printouts in your... Yes, I can see some coloured printouts. Okay, wonderful. So what I really wanted to do is to give you a resource that at the end of today you can take away, and you can make sure that every time you go to your IBS clinic you have this with you, because this summarises all of the results of those 35 different trials. And what it does is it breaks up the different trials, so you can see if you start at the top here, this is one particular probiotic, so everything above that grey line is the same probiotic, and then this is another probiotic, and then this is another probiotic. So what the GSG group have done is summarise all of the data for every single probiotic available on the market. So it should really help you. So a patient should come in, and if it's red, it shows that it doesn't work. If it's amber, it shows that the findings are ambivalent, and if it's green, it shows it was effective. effective in reducing that symptom. So what you need to do is look through that table, look at the symptoms that improved with which probiotic, and therefore when your patient comes in, you ask them about their predominant symptoms, the symptoms that bother them most, and then you should be able to make recommendations based upon that. So what I'm going to do now is briefly go through the probiotics that are available in the UK. Because unfortunately, although there are 35 randomised controlled trials, not all of the probiotics tested are available in the UK. The last time the BDA did this systematic review, they only did it based upon probiotics in the UK. So it was great for UK dietitians, but not for dietitians all over the world. So it's a much better improvement, but what I'm going to do is I'm going to talk about the trials of the probiotics that are available in the UK. Okay, so let's start off with Whelan. So this is a trial looking at Bifidobacterium infantis, and so this is the probiotic right at the top of that paper. So if you look at the your coloured handout, you can see that the first one is Bifidobacterium infantis 35624. So so there's lots of data there about whether you should be recommending Bifidobacterium infantis 35624. You can also call it Alflorex because that's an easier term to use. Look at the data, it's fairly mixed, if I'm absolutely honest. This is the biggest trial that was done with that particular one by Peter Whelan from Manchester, and what they did is in one of the trials they compared against a placebo 3 different doses of the probiotic. 2 really interesting points. Firstly, the trial ended at 4 weeks. A comment I would have is lots of the probiotic trials are very short in duration, only 4 weeks long. And you can see that this is the symptom severity, and so you can see that one of the doses is causing a reduction in the symptoms as it goes down. But what's really interesting to me is that it persists for a little bit as well, is that it seems that you stop and still 2 weeks later they're still a little bit better. I suspect if they'd have carried on measuring it, I suspect the benefit would have stopped if they'd have carried on measuring it for a little bit longer. But it was significantly reduced the symptoms. But what was really interesting, only one of the doses significantly reduced symptoms, and it was the medium dose here. So you can see this is placebo here, so you can see that the high dose didn't reduce symptoms, the low dose didn't reduce symptoms, but the medium dose did reduce symptoms. Actually, that was not because low dose or high dose doesn't particularly work very well, it's because how they formulated it. So what you can see is this is the high dose, and what they've done is they've opened up the high dose and left it open to air and moisture, and you can see it's still solid as a bullet. There's far too much in there and it won't dissolve when it goes into the gut. The low dose there just isn't very much of, so this is the medium dose. So what they suspect is the high dose didn't work because it never dissolved when it got into the gut. So, but the Alflorex that's now on the market uses the medium dose that was shown to be effective. So that's the evidence for that. I have to say there are some other trials which do not show benefit, and those are summarised on your coloured handout as well. So, but that's one of the positive trials for that particular species. I'm sure many of you have heard about this one. This is Simprove, and if you turn over your coloured handout, if you turn over, it is the one that is about halfway down page 2, and it's the one that's called 4 Strains, and it's by Sissons. So this was by Sissons, published in 2014. Simprove is a non-dairy probiotic, so it differs from the others, and you can see that in this large randomised controlled trial they had 186 people in this. They randomised them in a 2-to-1 ratio, so you can see many more people in the intervention group compared to the placebo group. But what you can see is that over a 12-week period the Simprove improved had a greater reduction in symptoms compared to a placebo. But it's really important to say that that was 12 weeks. So in your clinical practice, if you're recommending Simprove, you should recommend it for 12 weeks because that's what this study showed. You can quite clearly see that after 4 weeks of Simprove, there was no significant difference, and nor was there at 8. And so if you are recommending this particular one, you have to tell the patients that the only trial to show it benefited only showed it by 12 weeks, so you've got to keep going with it. So that's my advice there. Another study, sorry, I'm an old man, I've got to keep taking my glasses off to read in front of me and the screen here. So the next one is Activia, and that is, if we turn over onto the first page now, that's at the bottom of the first page, and so it's the paper I'm going to talk about is Agrawal. All of the ones there, those three studies, Agrawal, Guionnet and Roberts, they are all based upon Activia. What is really, really interesting is all of those trials are in IBS constipation. So somebody comes in with IBS constipation, you should be having alarm bells. This is the one where Activia has been tested. Not saying that Activia will not work in IBS diarrhea, but the trials to date have only been in IBS constipation. And so here's the study, a study of only 34 people. So remember I said there are some small trials, this is one of them. And this looked at women with IBS constipation, and you can see there were significant reductions in overall IBS symptoms, reductions in abdominal pain, flatulence and bloating. So if somebody comes in with IBS-C and they have those symptoms, then that's when you should be thinking of Activia. Sure, you can recommend it for people without IBS-C, but do know that it's not been tested in that population. So that should be your red flag. Oh, IBS-C, I should be thinking Activia. And then finally, the other one I'm going to be talking about, so if we now go to VSL3, VSL3 is the very, very last one on the table, and VSL3, you know, is a combination probiotic of these 8 different strains, a variety of different studies, many of which show it does not work, but I'm reporting now this Kim 2005, which shows some benefit for flatulence, and so you can see here that in these 48 different people, there was no impact on urgency, no impact on pain and no impact on bloating, but there was a significant reduction in flatulence. So again, somebody comes into your clinic with IBS and they have lots of flatulence, be thinking VSL3. Doesn't mean it won't necessarily work in other symptoms, but this study has not shown that. So what I hope is that this coloured sheet that we've given you will be a great compendium to take to your clinic, and you can look down what symptom does my patient have, and I'm going to look for which green boxes there are and which ones are available in the UK. Lots of limitations to those. I've only got 2 more minutes, so I'm going to leave you to look through those. The take-home message is we've got to do much better in terms of clinical trials of probiotics in IBS. So if you're interested in undertaking research and you're interested in IBS, this is where I would start. There's a real need for real good trials here. I'm going to mention there are 4 different RCTs of prebiotics in IBS, and I'm going to mention the one positive one. So there's only one positive one. So prebiotics are fermentable carbohydrates that stimulate the selective growth of beneficial bacteria in the gut, and the only one to have shown benefit is this trial here. This was published back in 2009 now using galacto-oligosaccharides, so not fructans but galacto-oligosaccharides. This is by Immuno, which is available on the shelf at the supermarket, randomized into 3 arms using low doses and high doses. And what you can see is that the low dose reduces bloating symptoms, so it improves bloating, but if you look at the high dose, it worsens symptoms. And this is going to be really interesting because I'm going to talk about why GOS might increase symptoms a little bit later. But low doses of this particular prebiotic reduced bloating, whereas high doses increased it. And I'll talk about why that might be later. So in conclusion, the pathogenesis of IBS involves the gut microbiome plus many, many other things. So don't get sidetracked just thinking about microbiome. There are loads and loads of clinical trials. Lots have limitations, but there are many beneficial effects overall on global symptoms, abdominal pain and bloating, but they're strain specific. So don't just read the meta-analysis, read the individual trials, look at that compendium you've got. Recommend patients take a selected probiotic 1 at a time, and they take it for at least 4 weeks. Those trials that have lasted for longer, I'd recommend that you recommend them for longer. The BDA guidelines are an essential tool to be able to work on that. Prebiotics in IBS, we're really not quite sure of the status so far, and only one good trial has shown any improvement. Thank you very much.